All right, well, welcome back, everybody. Thank you for joining us for the afternoon session as we continue our discussion on AMR and pandemic preparedness. And we'll start things off with a new transition. There have been new developments. Please watch.
Experts are requesting the expedited availability of diagnostics to identify the resistant infections devastating those infected with the pandemic influenza as well as a U.S. swine population. There are also growing concerns about overburdening the diagnostic labs. Regional testing centers for both the humans and pigs have received a record number of samples, slowing down turnaround times and ultimately delaying treatment. Infectious disease experts are concerned that due to the delay in processing results, stewardship practices are collapsing, and the physicians and veterinarians are both treating before they receive test results. Many are raising fears that both the inability to accurately test in addition to the diagnostic delays are exacerbating an already deadly pandemic.
Hey, good afternoon and welcome back. I'm Christine Giannacchio. I'm the Chief Scientific and Medical Officer for Quotient Diagnostics. It's my pleasure to open this session on diagnostics. As we are all very well aware, diagnostics has played a key role in the influenza pandemic of 2009 and from the start of the COVID-19 pandemic until even today. We steer our lives around rapid home tests that guide not only what we do, but what we also cannot do, but also helps us protect our communities. The COVID pandemic taught us that we can develop quickly high-quality diagnostics, and the traditional regulatory hurdles can be streamlined without affecting patient safety. However, beyond the diagnosis of the pandemic pathogen, we cannot forget the tragic outcomes relating to what I call the ride-along pathogens, the MRSA, the pan-resistant Acinetobacters, carbapenem-resistant Klebsiella, Candida auris, and fungal infections that contributed to COVID mortality. Often, especially in the early days of the pandemic, beyond COVID testing, if that was even available, little or no diagnostics were performed to actually determine if secondary infections such as community-acquired pneumonia, ventilator-associated pneumonia were present. And if testing was done, it relied on slow, insensitive traditional culture methods. The consequences were, in many cases, incorrect diagnoses and the blanket use of broad-spectrum antibiotics to hopefully reduce mortality. Additionally, I personally question if the rates of co-infections were actually grossly underestimated, especially when testing was done after the initiation of antimicrobial therapy. So our task this afternoon is to ensure that we are prepared with rapid diagnostics that go beyond the pandemic pathogen to address these other key issues: secondary bacterial and fungal infections, and the antimicrobial resistance pandemic that may emerge. In consideration of these issues, our esteemed panel today will speak to several key topics that will help guide us in understanding diagnostic needs that can help track and mitigate AMR pandemic, ensure availability and access to diagnostics, to help provide guidance for the use of diagnostics, very importantly, to drive treatment decisions, preparations for the development of rapid point-of-care tests aimed at AMR, and the need for accelerated communication through laboratory networks, particularly if a novel resistance mechanism arises that we may not be prepared to identify and correctly predict antimicrobial susceptibilities. So today our speakers are Dr. Kim Musser from the New York Department of Health Wadsworth Center, Dr. Jean Patel from Beckman Coulter, Dr. Tom Chiller from CDC, the Mycotic Disease Branch, Dr. Roger Main, Iowa State University, and Dr. Christina Loacono from the USDA and the National Animal Health Laboratory Network. So thank you, and I'd like to start with Dr. Musser.
Hi, good afternoon, everybody. I'm going to start by telling you a state public health lab perspective related to testing, diagnostics, and reporting. Next slide, please. So first, I just need to tell you that Wadsworth Center, New York State's public health laboratory, we're a large public health laboratory. We're not the example of the typical public health laboratory. So just keep that in mind, that there's a huge range among the 50 public health laboratories in this country. But we have a large staff. We have a lot of laboratory space. We have research programs alongside our public health testing that can help us, especially in something like pandemic preparedness. And we also play a regulatory role, which can and has been critical in some of our pandemic testing in the past. And building on some of the earlier talks in the first session, we are also a regional antimicrobial resistance lab network laboratory for the Northeast. And I'm going to tell you some of the roles we play as it relates to this scenario. Next slide, please. And so there's many, I think, as this whole audience knows, there's many different levels of antimicrobial resistance testing. There's the clinical laboratory role, initial testing and diagnosis. The state public health laboratories are there in green in the middle. We're doing confirmation, additional testing. In terms of antimicrobial resistance, we're looking for novel resistance determinants. We're trying to help do testing related to transmission in healthcare facilities. We're also providing some essential antimicrobial susceptibility testing that may not be available in clinical laboratories. And then, of course, in the blue, the federal level, there's a lot of many roles, but monitoring national trends, high-level advanced testing, and responding to emerging threats is there. Next slide, please. So the testing that relate to antimicrobial resistance that we perform on the left, in terms of our role as a regional AR lab network, we're doing a lot of carbapenem-resistant bacterial testing, CRE, CRPA, Pseudomonas, crab, Acinetobacter. These are some of the urgent threats, as well as colonization screening for those transmission events. And there's also Candida auris testing that takes place. As our state public health lab role, we also do some specialized testing for MRSA, VRSA, trying to identify if there are cases of VRSA, as well as a number of the other agents that were listed in the scenario, agents of bacterial meningitis, Legionella, to name a few. The types of testing that we're performing, we have advanced methods for AR. These include lab-developed tests, real-time PCRs, as well as commercially available tests like the Cepheid Carba-R test are really critical in rapidly identifying what AR agent is in this case in a patient, and we can do some of that testing in hours. We do that expanded AST testing that can take days. And then some of the new technologies that have already been mentioned, whole genome sequencing and bioinformatic analysis, some of that can take weeks. So just to kind of show you some of the different types of testing. Next slide, please. And how does this work in terms of reporting? So initially in our laboratory, when we're detecting carbapenem-resistant bacteria, we may be receiving cultures, as shown in this slide, and we're doing some additional culture testing as well as PCR, and then sending reports of what we've identified. When we do identify clinical cases, if they are transmissible AR bacteria, that often leads in work with our colleagues at the health department, our epidemiologists, to deciding to do the colonization screening. So we send out those materials to the facilities throughout the Northeast. We receive those back and perform PCR to see if the transmissible antimicrobial resistance genes are present. We then try to isolate those bacteria, and all of that also gets reported to the CDC, to our submitters. And then when we do find transmission events and we're able to isolate those bacteria, then we also try to connect clinical cases to the cases, the roommate, the people that are on the floor of the healthcare facility. Whatever the question is that has been sent, we will send a report with that information and provide information about, yes, it does look like this was a recent transmission event, or these bacterial isolates, although they're the same gene, are unrelated, and so we can do that work. Next slide, please. So this is a complicated slide, but I think this is really the crux of the whole talk. If you look at the New York State there with the blue, it's got a lot of different laboratories. We have more than 250 microbiology laboratories in New York State. Some are county laboratories, some are clinical laboratories, some are commercial, some are large hospital systems. But all of those laboratories are performing testing, and they are performing electronic reporting. They're also sending, in some cases, these isolates or primary specimens to Wadsworth Center, pictured there in the purple. When we receive those samples at Wadsworth Center, we're doing the tests that we talked about, but we are then reporting to CDC, the health department, also reporting our testing results to our health information exchange. We are sending sequences to NCBI so that those can be captured and others can utilize those. And then in yellow, very importantly, as we start to see changes and start to work with all the colleagues, we are sending laboratory advisories and testing updates. New information is being shared back to those clinical laboratories. So there's a lot of sending of samples, there's a lot of reporting, but there's a good infrastructure there. Next slide, please. And so every state also, along with federal requirements, there are state reporting requirements. And so we have our set in New York. There's a different set in New York City. And mandatory reporting by law within that state can be really helpful for some of this work, as well as isolate or specimen submission. And this is just showing you what some of that looks like in New York. This is really critical to make sure that you can really do good surveillance and be able to receive all the samples that would be helpful. We do this for foodborne disease, and we do this for many different important infectious diseases. Next slide, please. So the new tools, these have been mentioned, but just to show you a snapshot. So new tools for antimicrobial resistance, the whole genome sequencing, it's serving a lot of different roles. We're able to look for different types of AR genes that we're finding on plasmids and in the chromosome, in the bacteria that we're receiving. We're able to catalog them and understand them and look for changes. And then we're able to look for distribution within our state and within our region with the resources related to the AR lab network. Next slide, please. And then the new tools for doing some expanded susceptibility. So there is some testing that is not available in commercially or in clinical laboratories. And so by request, we're doing a handful of these each month to try to best treat really challenging, almost difficult to treat bacterial organisms. And we're using this great technology that the AR Lab Network has prepared for us. We're using HP printing technology, and this can be changed and maximized to for what the emerging threat may be, to try to be able to use this tool to be helpful for treatment. Next slide, please. And then just lastly, related to the scenario of the secondary antimicrobial resistance, a few considerations I just wanted to mention. So the clinical microbiology laboratory, for all of those, it's very important for them to be able to, during a pandemic, to maintain reporting, isolate submission and specimen submissions. We saw huge declines during the COVID pandemic. We were still able to stay operational, receive all the isolates sent to us, but there are certainly, when all the resources are put toward the pandemic, there are lapses and changes there. In terms of the state or regional health department, being able to provide those advisories and testing updates is really key. For all laboratories, implementing multiple options for testing, different platforms, different extractions to get the DNA from the organism, making sure you have multiple routes of this is really critical, because when there are supply shortages in a pandemic, with the main viral disease in this case, you wouldn't want that to impact the secondary work that you would need to do. In terms of the epidemiology and infection control staff, one thing that we still see as an issue, we do a lot of testing and reporting of antimicrobial resistance, but there are still so many challenges with our epidemiology and infection control staff that there's so much to do for the pandemic or the main infectious disease issue at the time that losing focus and not being able to maintain and have staff that are specific to something else like antimicrobial resistance, I think is really critical. Finding new tools like we've talked about already, but new ways for data visualization and integrating databases and finding new ways to make it easier to understand what's being reported and how to utilize that information. And of course, the communication between lab and epi and the public health labs and the clinical labs is really important in being able to respond to an agent like we're talking about in this scenario. And that, I think, next slide, I think that was my last one. Okay, I will end there.
Okay. Thank you, Dr. Musser. Just one really quick question to put this in perspective. New York State, I had the pleasure of working with you for 40 years. But how many other state public health labs do you think have that level of sophistication?
So in terms of the testing and the reporting, I think there's probably 10 to 15, laboratories that have large staff and the ability to do advanced testing. I think there's some in the middle that are much smaller workloads, and then there's some really very small public health labs. So I think it's only like a 20%.
Okay, thank you.
Sure.
Okay, our next speaker, Dr. Patel.
Thank you. Thank you so much for this opportunity to talk about developing diagnostics in an emergency situation. So in the situation that was described, a company like ours would stop and think about, well, what do we need to make more of? What do we have today that we would need to update in order to help? And what new diagnostics would be helpful? And I'm going to focus my comments on those last two categories, what would need to be updated and what new things would be needed. Next slide. And I'll talk about diagnostics in two different categories. The first one are diagnostics for an infection. That means the patient has an active infection. There's a pathogen that needs to be identified. There is a therapy decision that needs to be made, or multiple therapy decisions. We have diagnostics for this today, but these are slow. New technology is helping us with rapid diagnostics. Some of these are on the market today, but we really need to overcome accuracy gaps in order to have these diagnostics have optimal impact on antibiotic use. And tests need to be updated when new types of antimicrobial resistance emerges. The other category of diagnostics are diagnostics to prevent infections. So this is an infection, and specifically this is healthcare-associated infections. This is a patient in the hospital. This patient doesn't have an infection, but diagnostics might help to identify if this is a patient at increased risk for developing a healthcare-associated infection or for transmitting a multi-drug resistant organism to other patients. The interventions that exist today are infection control interventions like contact precautions and placing the patient in isolation. But new interventions are in development, and diagnostics could help to identify when these interventions should be used. The next slide. Here I show the pathway for collecting a blood specimen and testing it to identify if there's a pathogen causing a bacteremia. And this is a good opportunity to identify what diagnostics we have today for a critical infection like this. There is a molecular test for testing blood directly. This is blood without incubation. There's a single test on the market. This is the kind of test that can have a big impact on antibiotic use. This is a test that would be most effective if it were very sensitive and you knew that de-escalation was a safe decision to make because of the test result. There are tests to perform directly on a positive blood culture, or the PBC. These are molecular tests that will identify a pathogen and detect resistance mechanisms. These are tests that can be performed in less than 2 hours, and they can have a significant impact on therapy decisions, specifically for gram-positive infections. these diagnostics have much less impact on gram-negative infections. Rapid phenotypic susceptibility testing in less than 8 hours has been realized. There is a test on the market. This is a test for positive blood culture testing. These tests can also be applied to isolates from culture. And in the future, these tests may be in a format that testing isolates from culture could be done routinely. So that kind of test is a test that would have to be rapid. It would have to have a large test menu consistent with phenotypic tests today. It would have to have high throughput because there's a lot of testing that happens. And it would have to be available at a price point that the market could manage for routine testing. We know from rapid phenotypic susceptibility testing that this can improve time to optimal therapy by 24 hours. It is expected that if rapid phenotypic testing were applied more broadly and perhaps routinely, that this could have an even greater impact on patient outcomes. Next slide. So to address each of the gaps that exist today for testing, pathogen ID direct from positive blood, this would really require a technology breakthrough to increase sensitivity. This is a super challenging test, and that's because there are very few cells in a blood culture specimen. You need those cells to do a whole bunch of stuff. You want to ID the pathogen, you want to detect resistance mechanisms, you want to do susceptibility testing, and that's why incubation of the culture is needed today. Molecular testing for positive blood culture is a successful diagnostic. Work is really just needed to keep these tests up to date. And rapid phenotypic testing is a future challenge. Customers want speed, they want accuracy, they want a test menu that will replace a conventional test, and they want a price tag that rivals current costs. This is a big lift, but definitely possible. Really, to understand how these tests would most impact patient care, we need to understand how rapid testing or how prescribing in the healthcare setting could be adjusted to make the most of this rapid testing. Next slide. So when in a pandemic such as this, there is an expectation that new types of antimicrobial resistance would emerge, and industry would need to have access to the isolates. And this is necessary to show that a diagnostic test can detect the new types of antimicrobial resistance. It was fundamentally important for validation and verification to develop a test. The CDC FDA AR Isolate Bank has been a tremendous resource for these kinds of isolates. Industry needs to know knowledge of the clinical epidemiology. Who needs to be tested? What specimens should be tested? These are integral parts of assay development, and it helps to determine how the clinical trial for an assay needs to be designed to bring the test to market. And we need to know the size of the population. How many patients are affected today? How many would be in the future? And this really helps to understand whether the investment in test development is going to be a good business decision. There are different times needed for development. So a molecular test to detect a new type of resistance gene, the development time is less than a year. Phenotypic susceptibility testing of an existing drug would be something that could be accomplished in less than 2 years. But if there is a new drug coming to market and this needs to be reported for multiple bacteria types, this is a greater than 2-year turnaround time for test development. Next slide. I'll move on to diagnostic testing for preventing infections. So these are the kind of tests that could be applied to a patient who is hospitalized. This patient comes in with a diverse microbiome, but may be colonized with a multi-drug resistant bacteria. And when the patient is treated with antibiotics, this balance in the microbiome switches. And now the drug-resistant pathogen predominates and the good bacteria are in a minority or absent. This is a patient who now is at increased risk for becoming infected with the pathogen that has overcolonized the microbiome. And this is a patient who is at increased risk for transmitting drug-resistant infections within the healthcare setting. Some of the diagnostic tests you might consider here are MDRO colonization testing. This might be a test in the GI tract to detect a multi-drug resistant organism. The decision today will be whether that patient should, whether infection control precautions are needed around that patient. In the future, the decision may be decolonization with that pathogen. In addition to decolonization, this would be an opportunity to identify the pathogen that is overcolonizing the patient that might be the cause of a healthcare-associated infection. Identify that pathogen and do susceptibility testing. That will be the ultimate rapid antimicrobial susceptibility test. It could help drive empiric treatment decisions. There might be diagnostics to track the transmission dynamics of an MDRO pathogen, especially during an outbreak. This would be a microbial relatedness assessment, and this would help with infection control precautions. And then finally, there may be a need in the future, or even today, for a microbiome diversity assessment test. This is a test that could determine the diversity of the microbiome, whether this patient is at risk for over colonization with a pathogen. Today, there is no test like this that exists. It is not normal medical practice, but in the future, this might be a way to identify a patient who needs an intervention, such as microbiome protection intervention or microbiome reestablishment. Next slide. So we know tests like this are important. So MDRO colonization tests can resolve an outbreak or predict an HAI. And we know that CRE surveillance, so specifically surveillance in the GI tract at admission in a hospital, was independently associated with lower new carrier prevalence. And this is a study that came out of Israel, which used CRE colonization testing when they first identified transmission of CRE infections in that country. In a case-controlled study, a semi-quantitative PCR assay demonstrated that Klebsiella colonization density is associated with subsequent infection. This is a case where detecting that pathogen, quantitating that pathogen, could help identify what pathogen is likely to cause an HAI in that individual patient. So we know that transmission diagnostics can identify a common reservoir. And this was successfully demonstrated in an outbreak of CRE in NIH hospitals where whole genome sequencing was used to characterize pathogens. And we know that microbiome restoration works for stopping a healthcare-associated infection or a community-associated infection with Clostridium difficile. We know that in recurrent infections that fecal transplant is effective for the treatment of recurrent infections. If prevention of infections is our future and diagnostics then can help, then this is something that we need to start working on now and not wait for an HAI pandemic. Next slide. So there are market barriers that could hinder the development of prevention diagnostics. And this is an example of carbapenem-resistant colonization testing. And I'll tell you, this is an example that I experienced in my previous career at CDC, and then also in my current career at Beckman Coulter Microbiology. I need to add that Cepheid is a sister company to the company I work for under the Danaher umbrella. So the Cepheid CARB-R test is the only FDA-cleared test for detecting carbapenem encoding genes in a GI pathogen or a GI sample. This is a test that when it first came out was not taken up by hospitals, and when we were deciding what tests should be placed in the CDC AR lab network, a decision was made to put this test in the network, and then it is available for free to hospitals to use. There still wasn't a big take-up initially when this was placed in the AR lab network. There are multiple reasons why a test like this might not be used, and really I'm going to list a couple of hypotheses. One is that there is no specific reimbursement for an infection control test. The interventions are really infection control interventions, and if a healthcare provider believes that these interventions are ineffective or too hard to implement because they don't have enough isolation beds in their institution, then this testing is not desired. And this is not an everyday test for a microbiology laboratory. It can be hard to have a test that you use just periodically in your laboratory because there's a lot of kind of administrative work needed to make sure that this test is properly implemented in a laboratory. And that means that sometimes labs are not going to perform it in-house. It will be outsourced, and outsourced tests are always less likely to be accessed. If this is important, if MDR colonization testing is important, we really need to address issues that affect test utilization. There have been no other entrants in this market for colonization testing, and I think this was, this would be a hard business case to make inside of a company. Next slide. So to summarize, important infection diagnostic tests are already available and in development. Direct from blood testing could be improved with technology breakpoints. Rapid phenotypic susceptibility testing really just needs innovative test development muscle, and uptake will depend upon clinical impact studies. Is this rapid testing really important, and can it make an impact on antibiotic use and patient outcomes? Outside funding such as BARDA enables industry to take on more risky projects and still invest in our core and keep our current products up to date. Prevention diagnostics are undeveloped testing categories that could significantly impact healthcare-associated infection rates. We really need to overcome barriers to test utilization. Where new interventions are being developed, we have to stop and ask, will diagnostics help with implementation of these? And we need demonstration studies evaluating if diagnostics can help with these interventions. And with that, I'll wrap up. Thank you very much.
Okay. Thank you, Dr. Patel. Our next speaker is Dr. Chiller.
Thanks. I guess we're out of order. Sorry. Good to be with you guys again. It's been a few years, and I'm glad you're going to listen to a little bit of fungal expertise today. We've been talking a lot about bacteria, and we have obviously mentioned fungi, and so I'm hoping that I can make a few points today, and then we can have a little more discussion, and we can make sure that fungi are included in our thoughts about AMR pandemics. Next slide. So just start with the bottom line. The bottom line is we have limited diagnostics for fungi. It's good to follow Jean because she talked a lot about some of the potential exciting developments in the bacterial space, but we're even more severely limited and challenged in the fungal space. And so, our mainstay is blood culture, doing a Candida blood culture, but even that, which is easy to do and easy to grow when it's there, is still only 50 to 70% of the time positive, and probably half of our invasive Candida infections are not even in the blood. So those are almost impossible to diagnose. We need better diagnostics in that space. AFST, or antifungal susceptibility testing, is still not universally performed, and certainly for some of the harder organisms like molds, aspergillus, performed in very limited locations. And so we need to figure out a better way to get AFST out there, because we need to be able to give that information to our clinicians so we can treat patients. And I think one of the exciting things about the fungal field right now, for the first time in 3 decades, we are coming up with some new antifungals that are going to have new mechanisms of action. But what does that mean? That means we have to develop AFST so we can actually figure out when and if resistance develops, where it's developing, so that we can, again, figure out which are the appropriate drugs to use. Next slide. So I want to start, I love you guys' example of starting with a patient. So I'm going to start with a patient, actually, and sort of describe. So let's meet Zoe. Zoe's 38-year-old, healthy woman from the Netherlands. She presents to her local clinic with headaches, fever, sore throat, runny nose, and some joint pain. Next slide. She gets a rapid influenza test, which is positive, and she's given Ostamivir, so typical influenza treatment. Next slide. On day 3, unfortunately, she's worse and is actually admitted and given antibacterials, broad-spectrum antibacterials, for what they think is pneumonia. On day 6, as you can see here, she actually develops, unfortunately, respiratory failure. She's diagnosed with sepsis, and she's actually intubated. Next slide. So then, obviously, they perform multiple tests to try to figure out what's going on with her. And next slide. Throughout that testing, they don't find anything in particular, but 13 days later, she dies. She expires. Next slide. So when we think about an influenza patient that gets sick, we think about influenza as a possibility for why she succumbed to this disease. We also think of what we're talking about today, secondary infections. And I think the typical ones we think about in post-influenza are bacterial infections. We also actually need to think about post-influenza viral infections, because those can also be present, especially in the influenza diseased lung. Next slide. But in this case, unfortunately, because I'm here talking about fungi, as you can imagine, it was actually an aspergillus infection. And we are seeing this more and more in the post-influenza patient. Next slide. Here's just a little bit of data on something that we call IAPA, or influenza-associated pulmonary aspergillosis. It's sort of an interesting disease, because it tends to, at least in the post-influenza patient, which we sort of recognized after the pandemic, the H1N1 pandemic in 2009, that it's generally the healthy person who develops severe influenza who gets this illness. It's not your typical transplant recipient, someone on steroids, etc. And in fact, it's sort of a different looking aspergillosis. If you bronch these patients, you can actually see it in their lung, and so it's more of a almost colonizer of the bronchial system, and less so of a classic invasive disease, although it obviously does invade. Next slide. We saw something, as you probably all know, similar in COVID now, which we call Kappa, or COVID-associated pulmonary aspergillosis. There were a lot of reports of this disease coming out of Europe, and then we began to see many more reports around the world. And you can see that in the slide it says anywhere from 0 to 33% of patients in the ICU with COVID were being found to have this kappa phenomenon. Next slide. Just switching gears, we've heard a little bit of talk about CORIS in COVID, and you can see here that the pretty dramatic increase in Candida auris that occurred during the COVID pandemic. And, you know, this obviously was very concerning to us. We thought we were making a bit of a dent in the control of this organism, clearly for reasons we've heard about today, which include using a lot of antibacterials, challenges with PPE and infection control practices. C. auris is the perfect organism to take advantage of that sort of space, and indeed it did, and we saw it recur in places where we had it controlled, and I think it was up somewhere like 60% over the last couple of years during the pandemic. Next slide. So just going back to aspergillosis, and just our ability to diagnose it, there are a few different ways that we can do it, and I have just up here, not for you to remember, but just up here on the slide, just to talk about the fact that there are some antibody detection systems that are not very good. There are antigen detection systems that are actually pretty good for invasive disease in immunocompromised patients. And then there are some molecular methods that are actually looking fairly good, but none of them are actually available in the U.S. They're not, none of those are approved. And if you look at the next slide, there are several of these in Europe that are approved that are actually working fairly well, but again, not approved in the United States. And so I think this is one of the areas that I want to emphasize is that we need to do better in this country, especially in this kind of scenario if we're trying to diagnose these deadly infections. Next slide. Susceptibility testing for fungi, as I mentioned, is unfortunately not great. We have some basic methods available. You can see them up here. We have broth microdilution. We have the classic diffusion on plates, which of course it can be time consuming. And then there are some automated systems. Next slide. And the only one that is FDA approved are some automated systems for yeast. Next slide. For molds, Aspergillus again, which is one of the ones that we're concerned about. I know you all heard about Aspergillus last time I was here, about the azole resistant issues in that organism. There is only disc diffusion right now that is commercially available. Next slide. So one of the things that I wanted just to highlight in this slide is just the fact that when we look at surveys done to find out how AFST is being done in labs, you can see that there's somewhat of a diverse range. But when you look at the gradient diffusion or disc diffusion methods that we can use to identify mold, you can see that it's under 10% of labs that are actually doing this. So again, we are really challenged in this area, and it is something that there are groups working on this. There could be a lot more done if there was a bit more investment, and so that's one of the things I wanted to highlight for you today. Next slide. So I just sort of said what I said there, that there could be better automated systems for fungi. There could be better rapid tests developed. And as I just mentioned, excitingly, we're going to see some new antifungals in the market probably in the next 2 to 5 years. And we're going to need to, we already don't have great tests for the antifungals that we have now. We're going to really need to be thinking about developing new tests for the antifungals that are coming in the future. And I think next slide, my final slide, just sort of reiterates some of the things that we've heard about today, but thinking about it in the fungal space. And the first point is, I want you all to continue to think about fungi as important causes of antimicrobial resistance. And, they are here, they are increasing, and they're concerning, and we need to continue to put those at least on some par with bacteria as we consider these sort of scenarios, these sort of plans, and these sort of investments. And then the point that Michael and others have already made about sustainable funding obviously applies to the fungal world as well. A lot of the systems that we're using to generate the minimal amount of data we have in this area are not going to be sustainable if the funding expires. And so I know that's something that we've talked about a few times already today, but I'll end on that point and give you back the rest of my time. Thanks.
Thank you, Dr. Chiller. Certainly an underutilized area of diagnostics that we certainly need a lot of help with. Dr. Main?
All right, we're live. Good afternoon, and appreciate the opportunity to be here. As you said, the title I was given just to share is a bit of a perspective from a full service, fully accredited veterinary diagnostic lab with this title of role of diagnostic in herds, availability challenges and how they're used. Next slide. And so what I'm here representing today is an example of one of the full service, fully accredited veterinary diagnostic labs that are located around the country. Typically labs, veterinary diagnostic labs such as ours, are located in conjunctions with land-grant universities and or respective state departments of agriculture. In most of the veterinary diagnostic labs across the country that are of significant scale and associated with the land grant or state Department of Agriculture are a part of what's called the USDA's National Animal Health Lab Network. And Dr. Luakna will be visiting more about that in her talk. And what I'm providing is perspective about, we were really posed with a question of, well, what would you do given this scenario that's been played? And kind of as we thought through that, and we were just talking with Haley and Sarah as they reached out to us, it was like, well, they're asking us these questions, and it was like, well, that's kind of what we do every day. And so part of, I think, we want to share is this is kind of a little bit of who we are and what we do. Next slide. And so what I put this slide together was really just to kind of depict, to say, where do veterinary diagnostic labs fit in this space around protecting animal health, public health, and the safety and security of our food supply chain. The veterinary diagnostic labs really sit firmly between the attending veterinarians or the practicing veterinarians, and then have very close working relationships with our state and federal animal health officials, and principally play the role of supporting the practitioners' needs as they work to support the health and well-being of the animals within their care. Next slide. And what this slide represents is really kind of our an overview of our model of service. And again, as an example of one in these full-service, fully accredited veterinary diagnostic labs. And that our principal client is the attending veterinarian who is working directly with the producers, the farmers throughout the country. They are submitting samples with specific, sometimes specific diagnostic questions, and sometimes with clinical history of unknown diagnosis with certain ideas of things they would like to rule in and rule out. And when I say full service lab, what that means is kind of a one-stop shop of having the various different diagnostic ologies all under one given roof. Okay, we typically operate those as what we call sections within the laboratory, and essentially things come in, they're assessed by the diagnostician, the different pieces and parts go to the various different ancillary labs within the laboratory, and they're responsible for pulling the results and interpretation of the case materials submitted and in reporting out their findings and interpretations back to the practitioners. And we use this flow of case material not only in the provision of what we like to believe to be a world-class veterinary diagnostic service, but also it forms our teaching as the students are associated with and involved in observing and participating in this flow of case material, as well as it really informs the applied research programs. Next slide. And somewhat that might be somewhat unique in our food animal veterinary diagnostic space. Again, this is just our laboratory of our example, but is the distribution of service tends to be quite wide. So what this graph just illustrates is the distribution of our caseload at Iowa State and where in a given year and where those cases are coming from, and that's really being driven by the advent of really tremendous logistics that we enjoy in this country, with overnight shipping and then same day testing within laboratories to push those results back out to the clients. Next slide. And as it relates to our scenario here, as it relates to the scenario of the influenza and subsequent increase in AMR and secondary infections, obviously, there will be a significant role in the influenza A related diagnostics, and that is something that the laboratories the veterinary diagnostic laboratories are well in tune with as it relates to high throughput PCR testing and further characterization, either through conventional Sanger sequencing or NGS related technologies. And the sample types that we use in the testing methodologies that are employed for that are very high throughput and comparatively very straightforward. Back in the bacterial front, actually quite few molecular diagnostic tools used in that space other than NGS or whole genome sequencing that's typically used in the veterinary space can be used to look at AMR genes, but more conventionally used for epidemiological based purposes. Next slide. And this is just an example of bacterial infections are not uncommon as secondary to type A influenza virus infections. And so what this graph just illustrates is essentially a histogram of the most common secondary bacterial infections in cases of type A influenza and swine from at our laboratory, with that being the Streptococcus suis, Pasteurella, and the Glasserella that were again all mentioned in this exercise. Next slide. And what this graph just illustrates is what the bacterial diagnosis and susceptibility workflow looks like in our space as a veterinary diagnostic lab. One thing that would be probably somewhat unique in this space compared to our human counterparts would be much of the bacteriological testing and susceptibility is derived from tissue-based samples of animals that are being sacrificed on acutely affected farms and submitting those tissues into the diagnostic labs for testing. So essentially they're plated, culture and isolation. Then we use MALDI-TOF for isolate ID. We use a workflow called a sensititer for comparatively high throughput and what I would call quasi to semi-automated systems of scalable susceptibility testing, but again, based on conventional phenotype-based susceptibility and associated interpretations. Next slide. And then we report such findings out to our client on their given cases. Again, what was identified, and then the susceptibility testing, which is actually quite common across laboratories, this common panel of antibiotics that are run through on all of our food animal cases that provides them both an interpretation of susceptibility as well as the core MIC value. And then those, go to the next slide, please. And then those results, I can't read this, but and then those results are made available, of course, case by case submission back to the individual client. But then we also aggregate those results and report those in an aggregate form to help inform our clientele about the current trends and susceptibility patterns for given bacteria against the various antimicrobials in play. Next slide. And then we look at those as on an annual basis, and then we can readily look at what are the trends in those associated susceptibility patterns. And so the three I just showed here, again, were outlined in the scenario and happen to be the three most common bacteria in the face of type influenza A against some common antimicrobials that could be potentially employed in such a scenario. So it gives us a chance to be able to look at them, essentially what does the susceptibility patterns look over the course of time. Next slide. And so just showing that, next slide, for the different pathogens. Again, this is readily available information. Next slide. And then kind of rolling up here is that the use of diagnostics in herd health management, in this case for the swine medicine use cases, they're quite extensive. They're quite proactive, and actually 85 to approaching 90% now of the diagnostics that are run for informing the swine health herd medicines are what I would consider preventive medicine-based applications that are either assuring freedom, help mitigating spread, and so on and so forth, as opposed to sick animal diagnosis. They help drive population-level decision-making and associated herd management-related strategies, making decisions based on individual herds or what we call flows of animals, and flows meaning of animals that have begot from a common, generally source herd that is producing offspring and flowing downstream, or regions, and that those herd-level decisions and population-level decisions are using to then also inform, in the case of this antimicrobial situation, individual treatments that are being employed on the affected animals within those given herds. And there's a tremendous amount of epidemiology and population-based medicine that occurs in this field, because it's truly a population-based medicine approach to managing the health and well-being of such animals. And so in that, there's a lot of lots of bioinformatics that are being applied as the people are trying to use the best information they can to help inform both management decisions as well as vaccine selection and so on. Next slide. And so, as it gets in summary, kind of as it relates to the challenge and needs in the pandemic scenario painted here, that would be something that would be a national scale. The core of that really centers around effective and working industry, state, and federal partnerships. All such aspects of that need to work together and effectively. The funding to help support such surveillance and response and recovery-based efforts, the lab infrastructure and capacity to support an effective response, and that is unquestionably highly reliant upon this USDA National Health Lab Network, was some network that was started nearly 20 years ago now. And I can tell you is that our country is certainly bearing the fruit of those investments that have been made over the course of the past 20 years. And the current response that's been, and we've all been involved with the current high path avian influenza response, is certainly a testament to that. And so I think with that, I will yield the floor.
Thank you, Dr. Main. Same question I asked Dr. Musser. So how many of these laboratories are there in the United States that have your capabilities?
Right, great question. I think there's something like 60 non-labs across the country, but the diversity of those can be quite extraordinary. Okay, from very specific type labs to the full service, fully capable labs, like I mentioned before, and those ones that are at that higher level, you might say, I think there's 20 something of those, again, generally associated with land-grant universities around the U.S.
Okay, great. Thank you very much. Okay, our next speaker is going to be virtual. Pull that up. Dr. Loa Kano.
Hi there. Can you hear me okay?
Yes, great. Thank you.
All right, then I will get started. Hi, my name is Christina Loiacono. I'm the coordinator for the National Animal Health Laboratory Network, as Dr. Main mentioned, or the NALN. I am sorry I wasn't able to be with you in person today, but I really do appreciate the opportunity to participate and share how, on the national level, veterinary laboratories respond to viral disease outbreaks and are actually expanding into supporting AMR surveillance and response. Next slide, please. So I wanted to start with a little bit of background about the NALN for those that aren't very familiar. As Dr. Main mentioned, we were formed about 20 years ago in 2002 as a partnership between the USDA and the American Association of Veterinary Laboratory Diagnosticians. 12 veterinary laboratories were chosen to begin doing surveillance for about 8 animal diseases of high consequence that affect livestock. And networking these laboratory resources provided an infrastructure of facilities and equipment and personnel that were geographically accessible no matter where disease was detected. Next slide, please. So the NALN has grown quite a bit in the last 20 years. We now have 59, almost 60 state, university associated, and federal laboratories in 42 states. These laboratories provide surveillance and response now for 14 specific diseases. They include bovine spongiform encephalopathy or mad cow disease, foot and mouth disease, African swine fever, and influenza in birds and pigs, just to name a few. Additionally, the NALN has responded to new and emerging diseases such as swine enteric coronavirus disease, Seneca Valley A virus, which is also a disease in pigs that shows with vesicular lesions very similar to foot and mouth disease. It's one of our lookalikes. And then, of course, SARS-CoV-2. The NALN program office sits within the National Veterinary Services Laboratories, which are our national reference labs where official confirmation of these diseases occurs. Next slide. So the purpose of the NALN is the same today as it was in 2002. We provide early detection of significant animal diseases through targeted surveillance, rapid response through surge capacity testing, and appropriate recovery from an outbreak through testing high numbers of samples so that we can show our consumers and our trade partners that we are truly free from disease. Next slide. Okay, so in the response that I'll describe for the viral pandemic portion of our scenario is, as Dr. Main mentioned, very similar to what we are involved in right now. We have a high path avian influenza outbreak moving across the country, and actually our second wave is just starting up again. The biggest difference with this particular scenario is that secondary AMR epidemic, which is going to be relatively new for the NALN, but it also presents a wonderful opportunity to incorporate our NALN antimicrobial resistance pilot surveillance program that has been going on for about 5 years now. So as our scenario unfolds, more and more case-compatible samples from swine will be submitted to any one of the 43 NALN laboratories approved to test samples for swine influenza, and those are shown on the map here. And there are definitely a handful of NALN laboratories, such as Dr. Main's Iowa State University NALN lab with extensive swine expertise, where most of these samples will likely be sent. So, and as Dr. Main explained, the diagnostics on the viral side, those samples positive by PCR for flu A will then be further subtyped, grown up by virus isolation, and potentially sequenced. And there is a great potential that commercial subtyping PCR kits would be useful here, but likely we would be relying heavily on a sequence-based approach for subtyping and viral characterization. And then as part of the routine workup, all of these cases would also be submitted within the laboratories for bacterial culture and isolation, and then incorporated, hopefully, into the NALN AMR pilot surveillance program. So next slide, please. Okay. So many of the NALN labs approved for swine influenza testing are also part of the current NALN pilot program for antimicrobial resistance surveillance testing, as shown here with the purple triangles. This pilot has successfully demonstrated the viability of implementing a sampling stream for monitoring AMR profiles in animal pathogens routinely isolated by vet diagnostic laboratories and clinics in the US. The project provides AMR profiles for livestock reproduction and companion animals that are clinically ill. We focus primarily on antimicrobial susceptibility using standardized methodology, interpretation, and reporting mechanisms. We've developed a centralized data collection and reporting process whereby data can be monitored for trends in AMR phenotypes and genotypes to identify new or emerging resistance profiles. We can help monitor the continued usefulness of antibiotics over time and provide information back to our stakeholders, which includes veterinarians, regarding these trends. So based on the success of this pilot, again, over the last 5 years, it's being transitioned currently into a permanent surveillance program to monitor AMR profiles to enhance early detection, response to, and recovery from animal health emergencies, similar to what we're seeing again in this scenario. So testing associated with the outbreak, both viral and AMR, would be occurring in multiple NALN laboratories around the country. And through our routine data collection and communications, the efforts of the laboratories would become part of a larger discussion regarding the effects of the pandemics on the swine industry, particularly, as well as the significance from a One Health perspective. Next slide, please. Okay. So surveillance testing data for both swine influenza and AMR are reported regularly to the NALN program office. Swine influenza in real time through electronic messaging into our central database using an HL7 standard. And AMR data is reported monthly through spreadsheets that are uploaded. Results from the spreadsheets are then reported through a public-facing dashboard, which I'll show you here in a few slides. Also, state and federal animal health officials will be receiving surveillance data directly from the labs, especially during an outbreak situation. So data is routinely reviewed during regular discussions with both internal and external stakeholders, where areas of interest and trending are discussed. We have weekly internal calls, even in peacetime, where swine influenza is included in a long list of general updates on swine health. The USDA meets monthly with the Agricultural Research Services and CDC. We have an excellent, long-standing working relationship with the CDC Influenza Division, sharing information, isolate sequencing analysis for both avian and swine influenzas. So it would be during these various calls that the findings associated with the early stages of our scenario would come to light. And then as the significance of these findings becomes more clear and relating it back to One Health, we would be ramping up our communications. Next slide, please. So once this incident is recognized, we will go into response mode. Thanks to COVID-19, we have all become very well adapted, as I'm sure you all have, with the virtual communications. We've also developed, thanks to COVID, a better understanding of what information should be communicated and how often. So our internal communications include daily updates on all of the non-negative testing results at the non-laboratories, whether within the swine influenza testing or the AMR susceptibility testing. So all of that would be reported daily as far as non-negatives and significant findings. And then we would identify what would be coming into NVSL for confirmatory testing on the viral side or further evaluation on the AMR side. We'll touch base with the non-labs doing the testing individually as needed. And then we also have weekly non-laboratory response calls to keep the whole network up to date on the situation as it's progressing. Updates will be provided to the Deputy Administrator for Veterinary Services daily, and then discussions scheduled several times a week to address any issues that might happen. Regular calls with the National Assembly of State Animal Health officials and representatives from the swine industry will also occur. And then, as with the current high-path avian influenza outbreak, a Federal Incident Command Group, or ICG, will most likely be initiated, and we'll start meeting daily to provide a forum for communication among administration, field staff, and laboratory staff regarding the response. A national incident commander would be identified, and then federal incident management teams can then be deployed to assist locally with any of the response activities. And then to address the One Health perspective of this outbreak, NALN would hopefully participate in a One Health federal interagency coordination group that I would assume would be initiated and led by the CDC. This is how it worked with COVID-19 during that pandemic and proved extremely successful in our ability to manage the response on the animal side for SARS-CoV-2, and then how to relate it back with the epi and other aspects of the human pandemic. Went really well. Next slide, please. Okay, so to further communications regarding the AMR monitoring associated with our scenario, we would utilize one of the deliverables from our AMR pilot that I am pretty excited to share. This is a public-facing dashboard, and it has the potential to be utilized as part of a unified federal response when AMR profiles of concern are detected by a One Health partner agency, so USDA, FDA, CDC. Currently, we're reporting monthly for specific pathogens in specific animal species. The dashboard is interactive, so the pathogen and the animal species can each be chosen from a drop-down menu in order to see the MIC values for various antibiotics. Here I've chosen swine and strep suis, and you can see the color-coded interpretations, which are based on breakpoints identified for the animal species. So the gray boxes that you're seeing here indicate that animal breakpoints have not yet been identified for those antibiotics. So in this scenario, we would plan to transition surveillance within the program to cover the pathogens of interest. We would also increase the reporting requirements to provide closer to real-time data. And again, this information could be used for outbreak response decision-making, as well as by veterinarians when making treatment choices in the field. Next slide. Okay, and here's an option on the dashboard to see the same data with a visual comparison of susceptibility and resistance. Additionally, about 15% of the isolates from the current surveillance program are sequenced and evaluated for AMR genes. I'm assuming funding is available, we would ramp this up as well and begin comparing genotypic and phenotypic evidence for resistance. The whole genome sequencing data is submitted into the NIH NCBI on a quarterly basis currently, with uploaded data being released immediately for public use. So there is definitely a gap in understanding of AMR patterns in bacteria that cause disease in animals, but having this national level information on AMR in animal pathogens is an important component of addressing AMR at the federal level. So the scenario that we're reviewing today provides a really excellent example of how the non-AMR surveillance program can be used to fill some of the gap and respond to an outbreak situation. So again, I really do appreciate being included today. And with that, I'll turn it back to this. Thank you.
Okay, thank you very much.
Produced by the U.S. Department of Health and Human Services.